Aqua. I'm going under, and this time I feel there's no one to save me. This all or nothing really got a way of driving me crazy. I need somebody to heal, somebody to know, somebody to have, somebody to hold. It's easy to say, but it's never the same. I guess I kinda like the way you numbed all the pain. Now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, then you pulled the rug. I was getting kinda used to being someone you loved. I'm going under, and this time I feel there's no one to turn to. Loving got me sleeping without you. To know, somebody to heal, somebody to have, just to know how it feels. It's easy to say, but it's never the same. I guess I kinda like the way you helped me escape. Now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, then you pulled the rug. I was getting kinda used to being someone you loved. And I tend to close my eyes when it hurts. Sometimes I fall into your arms. I'll be safe in your sound till I come back around. For now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, and then you pulled the rug. I was getting kinda used to being someone you loved, but now the day bleeds into nightfall, and you're not here to get me through it all. I let my guard down, then you pulled the rug. I was getting kinda used to being someone you loved. I let my guard down, then you pulled the rug. I was getting kinda used to being someone you loved.
Everybody loves to the way you move. Everybody here is watching you. I'm true. Alone before I go, 'cause I've been by myself all night. I used to know you look like a movie. My God, this reminds the last time that we might be exactly like we were before we realized we were sad. It's just like a movie. It was just like a song. I was so scared to face my fears, 'cause nobody told me that you'd be near. swear you moved overseas. That's what you said when you left me. You still look like a movie. You still sound like a song. My God, this reminds me of when we were young. Let me photograph you in this light, in case it is the last time that we might be exactly like we were before we realized we were sad of getting old.
Okay, dear our online participants from Malaysia, Thailand, Indonesia, and Philippines. In a few minutes, we will start our Nursing International short course. Please turn on your camera during the event and pay attention and enjoy our guest lecturer today. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Welcome back to our Nursing International Short Course Update in Tropical Nursing and Medicine, an issue of infectious disease, clinics and community, Day 2. The honorable all guest speakers from University of Muhammadiyah Malang and Mahidol University, and also our participant from several countries. In this morning, we will have lectures from Dr. Heni Tri Rahayu, PhD, and Professor Kesini Choti Vanik from Mahidol University. For the first material presentation, we will have a Dr. Heni Tri Rahayu, MS PhD from University of Muhammadiyah Malang, entitled the material about the infectious disease following the natural disasters. For Dr. Heni Tri Rahayu, the presentation will be moderated by Ms. Juwita Sari, Master of Science from University of Muhammadiyah Malang. Now, we will have the first material from Dr. Heni and for Mrs. Juwita Sari. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity from Miss Olivia. It is such an honor for me to become a moderator this morning. And today, I would like to greet all of the participants, the honorable of this morning short course, International Short Course on Nursing, and for all the committee and head of this short course of nursing. And thank you for all your time to joining this morning session. The first, let me introduce the CV of our first speakers. Our first speakers today is Mrs. Heni Tri Rahayu, philosopher doctor, and she graduated from National Cheng Kung University for her pursue the doctoral degree, and she was expertise in self-management of diabetic and nursing care. And then she also had published several articles from 2019 until 2022 regarding to psychometric properties, and then all about the diabetic self-care management. And then she also had many grants and awardee of LPDP scholarship for the last philosophical degree. And then now, allow me to welcome our first speaker, Mrs. Heni Tri Rahayu, philosophical doctor, for share her expertise and then the knowledge. Now, time is yours.
Thank you, Mrs. Juwita. Can you hear clear my voice?
A little bit louder, Miss.
Okay, first I set my. Okay. Now is better?
Yes, getting better, Miss.
Okay. Firstly, I want to share my PPT first. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you. This is a great honor for me that I have opportunity to share about the knowledge, and also talking about today's session. My topic is infectious disease following the natural disaster. Okay, this is the outline that I would try to talk this morning about the communicable disease in the shelters, concept of the shelters, status planning for the infection prevention and control in Indonesia, nursing load and challenges. Okay, let's get started. Before I talk, I want to greeting to the participant from the abroad, from the Malaysian, from the Thailand and also Philippines. Thank you for joining this event. Okay, as we know, this is the kind of the world disaster that mentioning in the worldwide reading. This is mentioned, for example, like flooding, but fire, tornadoes, volcano, landslide, earthquake, avalanche, drought, tsunami, and hurricane. Of course, this kind of world disaster is depend on the where the country is located and also the geographic situation in the every countries is different. So it's mean that the natural disaster in the every country maybe is different. What are the natural disasters? Actually, evidence suggests that natural disasters is divided into three main groups, which is called the group is hydrometeorological disaster. For example, like floods, wave surge, storms, typhoon, hurricane, and tornadoes. And the second is geomorphological disaster, for example, like landslides and avalanches. And the third is about the geophysical disaster, for example, like earthquake, tsunami, and also volcanic eruption. As you see in the right side, there is the number of the natural disaster by type of the event in 1980 to 2019. As you see here in the colors, about the hydrological and meteorological disaster is occupy the highest number every year. And this is about this picture mentioning about the natural disaster in Indonesia, which happened in the 2021, which is count about the total disaster happened in the 2021. Indonesia reached over 5,400 natural disaster in Indonesia, which is, as you see here in the map, the color is dark orange and also the red one. It means that the dark orange and also the red one is mean the highest incident rate in the natural disaster, almost in every part of the region in Indonesia. And you see in the left here, this is about the kind of type of the natural disaster that happened in the Indonesia. The first rank is for the flooding is here, reach about 1,700 incident, and following by the extreme of the weather, reach about 1,500, and also the third rank is the landslide, about 1,300. It means that Indonesia currently is having the higher threat about the natural disaster which happen in the part of the Indonesia itself. I'm pretty sure that you already knowing about this one. You have read the news about the last few months ago, November 21st, 2022, there are earthquake. The big earthquake happened in the Cianjur, West Java, Indonesia, which is caused very damages in the so many kind building that destroyed, and also so many loss, not only for material but also the life. And also the second, not far away from, not long from this kind of earthquake, in another part Indonesia also happened in December 4th. There are the Semeru mountain has saw the activity, which is there are about 72 hours of hot clouds, Semeru mountain in East Java, and it's also, as you see in the picture, is affecting the surrounding environment. Of course, it means that it also not only affecting the economical, but also the health situation in our population around there. Later on, we will talk more about the flooding, because the flood is this is the highest number in every world. And this is the two chart here is mentioning about the number of natural disaster in 2012 and 2022. And you see here, the green one and also the blue one is mentioning about the highest number of flood, including compared with another natural disaster. And how about flood in Indonesia? Because Indonesia has a high frequency of rain and the potential flooding in the most area in Indonesia. So it means that our countries, Indonesia particularly, has the highest threat about the flooding itself. And it means that about 80% of them occur within the last 10 years. And you see in the right side here, this is the news about from the BNPB. BNPB is one of the emergency or the disaster management bureau in Indonesia, reporting that over 3,500 natural disaster or flooding happened in our country in 2022. This means that's so high. What are the impact of the flooding and big natural disaster? The first is if we talk about the flooding disrupt the economical by interrupting the agricultural production and also damaging the transport way. So it means that it's affect all kind of the situation in including the economical and also the healthcare system in this population. And this is the undermined statement that infrastructure officers and also public facilities and also the flooding causes communicable diseases. Based on the Ministry of Health, is reported that the outbreak of diarrhea and leptospirosis happen when flooding is observed. And there is the report from the BNPB about over 2,600 people evacuate and stay in the temporary shelters. And this is, as you see the picture here, this is the problem in the shelter, why we connected this situation to the healthcare system. So because when we're facing the situation in the shelter, there are overcrowded living conditions, and maybe we are facing about the water and food pollution, poor sanitation and personal hygiene, environmental changes such as increasing the factor of breeding site and also high exposure to the proliferation of the disease factor like rodents or mosquitoes, and also poor nutrition and human, which is maybe some of the healthcare system in the shelter didn't cover the vaccination coverage, and also limited healthcare. So it's of course all of the factor here can make the outbreak of the disease occur easily. And you see here, this is the situation example that we found in the sector, particularly in Indonesian situation. Okay, so what are the communicable diseases during the flood and natural disaster in the shelters? Based on the reference, we found that the communicable diseases associated flood and natural disaster is divided into three category, which is the first is about waterborne diseases like diarrhea, and second is disease associated with crowding like the acute respiratory infection, and the last is about the vector-borne disease, about, for example, the disease that bring by the mosquito like the dengue fever or malaria. And you see here in the right side, this is another list of the communicable diseases that occur in the flood or natural disaster, for example, like diarrhea, cholera, dengue, malaria, acute respiratory infection, leptospirosis, and also hepatitis B and E. I want to review a little bit about the leptospirosis. Maybe we can find what kind of we can aware when our people in the shelter has the kind of the symptom. For example, like here, the first is the symptom of the leptospirosis is like a fever, and then someone will feel chills, and also headache, vomiting, loss of appetite, muscle pain, and also redness of the eyes and cough. As you see in this kind of the symptom, you maybe didn't recognize or realize that this is maybe the symptom of the leptospirosis, because maybe we can just think that this is only ordinary our common cold or common chill, something like that. But actually, when when it happened in the shelter after the, for example, like the flooding. So we can just thinking about another kind disease, which is about the leptospirosis. How the leptospirosis is spread is when the natural disaster, for example, in the especially in the flooding, which is there is so many water that cannot moving. So this is the bacterial leptospira can spread in the water, and then it's contaminated by the maybe rats, rodent, or also the urine, and there is can contaminate it to the directly to the patient or to the people, and or maybe indirectly will contaminate to the water, soil, or food. When this is the right side here, explaining about three kind of the method when the leptospirosis can come to the bodies. For example, like placing contaminated water or urine of the rat into the eyes, and also maybe someone that's swallowing contaminated water and food, and also maybe there are exposing open wound or cuts to contaminated water or soil. So three kind of the method can spread the leptospirosis happen, particularly when after natural disaster happening. And how about the shelters? What is the shelters? Shelter is the refugee established for the general population for providing protection, food, clothing, and minor first aid. The shelter range from the community evacuation centers to basic care facilities, and the shelter maybe can be a residential site, such as the dormitories or campsites, or maybe non-residential sites, such as the church, school, or sports stadium, which we can use to shelter for our refugees. And based on the EPIC, EPIC is the Association of the Professional Infection Control and Epidemiology. They're mentioning and they have the standard of shelter that to prevent the infection disease in the shelters during the natural disaster. This is the standard. The first is about triage and surveillance, and the second is isolation precautions. The third is placement of the individual, which is we can have the special placement for individual that contaminated, or maybe we argue that someone has the disease. And also hand hygiene protection, PPI, or personal protective equipment, and IPD, maybe also sexually transmitted disease. For example, we can provide the condom for the during the shelters, and then water management, food safety, waste management, and environmental decontamination. This kind of the standard must be have. This is the international standard. However, in Indonesia also has their own minimum standard based on the Ministry of Health of the Republic of Indonesia. This the minimum standard of the Southern Indonesia must contain about provide the immunization coverage, and also food, water management, waste management, toilet, personal equipment, and also placement for the individual. And however, currently the Southern Indonesia still focusing to fulfill the basic need and the first aid, not integrated the infection prevention and control yet in the shelter. So that to reduce the risk of the secondary disease transmission in the shelter, we need to implement the appropriate infection prevention and also the control measure. This is the shelter planning for the infection prevention and control in Indonesia. We can do the two kind of the implement appropriate infection prevention and control measure, which is integrated of two. The first is triage in the infection control, and the second is isolation. Triage is the first line to prevent disease transmission, which is triage is the process of the determining the priority of the patient treatment based in the severity of their condition. And this triage in infection control purpose that to identify the potentially contagious individual who require the isolation. And what time for the triage? There are 4 times at least when we can do the triage for our refugees. For the first time is when the refugees upon arrival or admission to the ACC. ACC is Acute Care Center. And the second is the additional periodic screening, so be considered when the result is low or maybe available. And the third is screening or assessment interval to be determined by the IP or infection prevention team and will depend on the risk assessment on the agent of the disease involved in that event. And the last is about when the transferring individual to another healthcare facility, we should have the triage method. Triage ordered by preference is there are two conditions. The preference, the first is for the healthcare provider and professional on site. And the second, we can also use the triage using the designated trained CC or acute care center worker or volunteer that has been trained to make a triage to differentiate our patient. This is the example of the triage that we can use to deliver or to identify the symptom in our refugees for our patient. The first is for example, when we want to assess about the respiratory disease, we can have this kind of the symptom or syndrome, the isolation precaution category, and individual placement aspiration and required medical profession. This table here mentioning about, for example, like if someone have cough, runny nose, watery eyes, we also need we only need the isolation for standard category, and we don't need to have the individual placement or aspiration, and it's no need to require medical professional assessment. However, if someone has the cough and also maybe fever plus accompanied by the fever, for example, the fever is the temperature is like 1,101 Fahrenheit, or maybe in the Celsius is about over 38.3. So it means that we need more attention. The isolation maybe droplet, or maybe if the cough is accompanied with bloody sputum and also weight loss, so it's the isolation is higher standard. This is the airborne disease, and also we need like individual placement. Only maybe we need like special distancing, or maybe if the like disease if the weight loss is accompanied with bloody sputum, maybe we can just think that maybe someone that has the tuberculosis disease. So it means that it's need the ARIL. It means that the airborne infection isolation room, yeah, or negative pressure area or room, and also the spatial distancing. And of course, all of kind of this fever need required medical professional assessment. And what also when we try to assess about diarrhea and also vomiting here, if the only vomiting, maybe this is need the standard and social distancing. But if watery and explosion stool with or not blood, maybe it is we try to hire a precaution category with the contact and also cohorting the spatial distancing. And also if in the skin, if someone has argue or had complaint about the skin rash and also maybe eye infection, it means that it is higher level of the precaution category. So it means like we can all of these kind of condition need to special distancing and also need require the medical professional assessment. And how we can interpret for using this kind of the trials. For example, like if the disaster is in infectious disease disaster like bioterrorism or pandemic, and the causative disease is known, the appropriate isolation precaution for that disease should be used. And also the spatial distancing is involved the separating the potentially contagious person from the others by a distance at least 3 feet or maybe around 1 meter. And we need to transfer the medical facility as soon as possible. And the social distancing for eye infection and vomiting consists of the interaction of the symptomatic individual or parent. It means if the patient is individual, is child, so the remain with the it's to remain with the family unit. and away from other individual in the shelter. And also we need to try to perform the frequent hand hygiene and to inform the shelter worker if the symptom progressive. And the last is this action should be continued until the symptom is subside. This is the example of the triage checklist. In the left here, there's the syndromic surveillance assessment of our triage from here, which is from the cough, or maybe you can just tick here, arise or something else. And also this is the poster, the example of the syndromic surveillance poster for shelter that, for example, like the following symptom condition should be reported to a shelter worker as soon as possible, which is when we can find like this. So we can put this kind poster in the shelter that can our refugee can read it. And also this is the example of the cover, the ethic, or the when someone have cough, like cover your cough, something like this. We can also put this kind of the cover to the patient. And this is also the cot and sleeping pattern to reduce the risk of the disease spread. For example, when someone has, we can put like this. So it's the exact or the right position is like this. So the head here and that here. So because so it's to reduce the risk, the spread, not spread, for example, from the cough, because it's not directly to the other person head, something like that. So it's like over something like this. This is the pattern to reduce the way to reduce the risk of the disease spread. And also we can put the wash your hand. Maybe this is the one of the hand washing procedure, and we can put it in our shelter so that our refugee, our people can read it, and also we can have disciplinary for the hand washing every touching with others. And also maybe putting the PPI, the glycol, mask, respiration, Google, or something else. And also how to removing is we need, this is actually the standard from the EPIC, as I mentioned previously. And also the water management, for example, for the water decontamination method, we use the boiling water, like place the water in large kettle or pot, bring the rolling boil, then allow the boil for some 4 minutes and something else. And also this is the example of the when we dispose something, the therapist, for example, or regulate medical waste or RMW should be placed in the right bag, or the container or the bag container should be labeled as RMW, something like that. So this regular crash scan, and we have this kind of the standard. So when we taking care in the shelter, we can do it as a minimum standard. For example, also like this one for the care beds or the waste product, we can disposal based on the type of the waste. For example, like stuff container, right bag container, regular trash, something like that. There are at least 3 kind of the type of waste that we can differentiate each other when it's disposal. And the last is about the sharing toys. It's very important that our refugee, particularly for the children, usually there is sharing toys, because we know that in the refugee, the condition, the mentally condition is affecting our children. So sometimes they share or have the toys together. So when to reduce the chain your child to being ill, so it's like limited to sharing toys, and also maybe if we forced to be sharing, so it means that we need to have the regular hand washing after touching the toys, something like that, toy, spoon, or something else. And what is the nursing role in the infection prevention during disaster in the sector? So there are three roles that we can use or we can do in our shelters. The first is infection. We can do the infection prevention coverage, which is consists of the design infection prevention program, or we can coordination with the local healthcare facility and public health communicable diseases officer, and also we can do the health education for our people. And the second is we can do the surveillance. The nursing can do the surveillance, as I mentioned previously, which is consists of the data collection, reporting, and monitoring of the disease. And the last is we can provide the patient management, which is including the triage, isolation, immunization, and transporting, and also decontamination. And this is the future implementation plan, which is there are 4 minimum plan we can derive from our roles. The first is develop procedure of the triage in the infection prevention. The second is advocating for integrating infection prevention in the shelter. And the third is socialization procedure of the triage in the infection prevention and monitoring and evaluation. And there is all of my presentation or my today. I hope all of you can be a good nurse, which is a good nurse is one who works based on the knowledge and sciences and who can provide caring work happily. Thank you. I come.
Thank you, Dr.
Okay, thank you. I come back to Mr. Suita.
Okay, thank you, Dr. Henning, for sharing your very excellent topic about infectious disease following natural disaster. That's very inspiring us much. And now we can move to the discussion and interactive session. So we give opportunity for all of you to ask several questions. It could be from chat column or could by raise your hand by pressing the raise hand button. Okay. So this is the first opportunity going to Mas Nasmi. Okay.
Baik.
Maybe you can introduce yourself first
Ya.
using bahasa. It can be using English.
Baik, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Saya Nazmi Fadizaki dari Keperawatan kelas B tahun 2019. Untuk pertanyaannya, apa yang bisa dilakukan perawat ketika manajemen bencana itu terjadi berbarengan dengan pandemi? Seperti itu, Bu. Seperti yang terjadi kemarin.
Oke. Terima kasih, Mas, pertanyaannya. Thank you for asking. Maybe can answer by Miss Henny.
Okay, thank you for the question. Nasmi ya, terima kasih ya. Tadi the question is about what we can do if the natural disaster happen during the pandemic. Yes, actually, the pandemic, for example, like last pandemic is our COVID-19, which is currently still coming right now. And also the natural disaster has been also threatening around our country. And yeah, as I mentioned previously, because the communicable diseases is spread between the airborne and also the waterborne. Because the pandemic now currently for the COVID-19 is the airborne. So it means that it's one of our priority also. When in the shelter, we can do the plan for example, managing our refugees, like we can do the position like that. And previously I mentioning the picture, for the position of the sleeping patient, one by one, not directly face to face or head to head, for example, the first one. And also you can everybody has the PPI, the protective, like using the masks, and also have the social distancing, or spatial distancing or something, at least 1 meters quarterly in every person. We can do like that. And also some, as I mentioned previously, also we can also have for example, when our refugees didn't have the vaccination, so we can provide the vaccination program. Actually, our Ministry of Health also provide the standard when in the refugees in the shelters, we can also have the standard to provide the vaccination, particularly for the airborne disease. For example, like the COVID-19. It's similar with our previously discussing. Before, actually, the standard is derived before pandemic, but actually this used to be like a general airborne disease. However, currently it's pandemic and also the COVID-19, also the airborne diseases, it's so included in the one of the disease that we can cover and we can do the prevention to spreadness in our refugees, something like that. Is that answer your question, Nasmi?
Oh yeah. Thank you.
You're welcome.
Okay, is it pretty clear, Mas Nasmi? Okay, thank you, Miss Henny, for the answer. And then we move to the next questions. It available in the chat column. The second from Mbak Mega Anggraini. I want to ask, what things should we concern as health workers so that the disaster mitigation activities can run well and suppress infectious disease, Miss?
Okay, thank you for Mega for the question. What things should be concerned as healthcare worker so that disaster mitigation activities can run well and suppress infectious disease? Of course, the first, actually, I also has been mentioning previously. The prevention that we use the standard for the prevention control infection disease in the shelter is to suppress infection disease within the natural disaster. Actually, when I was, maybe I want to try to tell my experience when I was in the master degree in the National Technical University, maybe in the 2012 last time, we learned about disaster management. And actually, the healthcare worker or healthcare professional has very high role in the this kind of natural disaster. Of course we cannot do the prevention for like for geographical or prevent how the disaster cannot happen, but we can do to suppress the limit of the limit or suppress or reduce the risk of the health problem that happen after disaster coming. As I mentioned previously, and also I will tell in my PPT, the standard there is the way that we can use to make our population in the particularly the refugees, when they in the shelter, we can suppress the infectious disease from the standard of the infection control spreadness, something like that. So yeah, we just have the mitigation, disaster management. We actually, there are one of the course, particularly in disaster management, special for the nursing and also healthcare provider. We can do together, not only for nursing, but also have working together with doctor or physician, and also maybe the physiotherapist and also the pharmacist. We can work together in when we facing our refugees in the shelter, and the first one is to reduce this infection disease. Maybe we can do another one, because the disaster management mitigation actually not only for the taking care for the communicable disease also, but maybe some part another professional can do another part, such as for mentally, and also another effect for our refugees, something like that. Yes, maybe in our, for example, I just suggest maybe in the future in our country, for example, when in the region that maybe the higher risk of the natural disaster, and also every year maybe they always have the flooding, always have the maybe landslide or something else. So we as the professional can have the training or mitigation to our population, our people in the like a community service, something like that, before we can just teaching them how they can provide or can survive, particularly in our major about the health. When natural disaster happen, so we can have the education, the health education to them, something like that. Yes, definitely. The mitigation is mean that we can have the preparation for our population before the natural disaster coming, something like that. This is Mega.
Okay. Okay, maybe Mega can give feedback through a chat column. And while waiting for the responses of Mega, one question more, Miss, from Mbak Afidatul Mu'arifah. I want to ask about if disaster can be avoided. How can disaster risk be reduced so that disaster can be avoided or reduced, Miss? Still muted, Miss Henny.
Oh, sorry. Okay.
Okay.
Yes. If disaster can be averted, yes, of course. But actually, we cannot. Oh, yeah, I mentioned previously because the human cannot force the God to press that there is no natural disaster. But actually, when I ever attend the disaster management coming from Japan, Hong Kong, and also China, they share experience when they have the big natural disaster and they have survived from the natural disaster. They said mentioning that the natural disaster cannot be avoided, real avoided, but actually we can have the many kind of the prevention that can reduce the effect of the natural disaster. For example, like when you is like a geographical professional, for example, we can have another kind modification for building or maybe you when combined together, because not, for example, I want to talk about the experience when Japan is mentioning about this one. The expert Japanese from Japan say that why Japan is actually Japan every year, even every maybe minutes has the earthquake, but earthquake is not really high, maybe, yeah. Also Taiwan also every, maybe if you ever live in Taiwan, you will maybe have experience about the earthquake, like it's different in Indonesia. As my experience in the first time I feel an earthquake in Taiwan, I feel very consciousness and very anxiety. But actually, people there is no why, because they are accustomed, or maybe they used to has the earthquake every day, maybe even maybe at least every week, every month, always earthquake. But why didn't they rarely have the like destroyed the building is destroyed like Indonesia, like the bigger earthquake in Indonesia is destroyed many times, because they learn in the past when they ever have destroyed many building when the first earthquake bigger in Taiwan, for example. But actually after that they move and then to try to rearrange about the construction of the building, that this used to be no, this is good for earthquake. So when the earthquake happened, so the building is safety. Now this is the point. We cannot avoid the earthquake. We cannot avoid the mountain exploded, but we can prepare our around environment to have survive between this natural disaster, something like that. So maybe Indonesia in the future will have like the expert to make a building that is can avoid the earthquake. So it's meant when earthquake happen, it's okay, no problem, something like that. Maybe in the future, maybe 20 years later, or maybe we hope, something like that. Yes, something like that. Siapa tadi? Hafida.
Hafida.
Yes,
Yes.
yes. If you interesting to learn about disaster management, you may learn this. Is it in for another country like Taiwan, Japan, Hong Kong, because they were the most biggest natural disaster for like the tsunami and also, but they survived better than us, something like that.
Okay, thank you, Miss, for the answer.
Yeah, thank you for the question also.
Okay, it is very clear, yeah, Mbak Hafidatul. So we hope so that many subsystem will be followed, yeah, in Indonesia, so we can create the best mitigation system and we can prevent all disaster better. And then maybe it can be one more question or someone who would like to join through live session. We wait for asking more. If there is someone still want to ask, please welcome to raise a hand and press your button. Okay, Mbak Dinda Putri Safira, you can turn your microphone on.
Okay, thank you for the opportunity. My name is Dinda Putri Safira from Nursing Department Class C 2019. I want to ask something related to problem that can occur in shelter. If there is only one shelter available and it causes overcrowded and there are no other shelter there, what can nurses do to prevent problem that may arise in shelter considering the large number of people there and sanitation is difficult to control? Thank you.
Yeah, this is the interesting question. Thank you, Tinda. Yeah, this is what happened in Indonesia, in our country actually, because we don't have the special shelter that we prepared previously in our government. Maybe average shelter that happened when the natural disaster come, just shelter make temporary, something like that. This is our lack resources. Yeah, this is our I don't say like, but maybe poor. If I compare to, for example, when I learn in Taiwan and also the experience in from the Japan, they have the actually if the government aware that maybe in one of the region has the high risk of the disaster, they should have put proper shelter for our population. But yeah, because we don't know, maybe, oh, okay, natural disaster cannot be predicted. For example, we can agree something like that. Yeah, this is our lacking, yeah, lacking facility. We cannot avoid it. When we're facing very large people in the very small area for shelter, of course, it's very, very far away from the standard. It means that we need to more evacuation, something like for the prevention, something like for example, like we do need for the personal PPI. For example, we use very clearly using the mask and also, yeah, I actually I cannot answer clearly because yeah, this is our limitation in our country. When we have large people in the very crowded, of course, the higher risk of the infection spreadness is the highest in here. But we cannot do anything that we try the best, our best to still prevent the disease spreadness in between in natural disaster in the southern. However, maybe our government in the future, we hope that maybe they can provide more facilities for our refugees, for the victims, for the natural disaster. But actually, as a professional, as a healthcare professional, we can do our best. For example, like particularly in the for physical distancing, if we cannot do the physical distancing, at least we can have like maybe use the mask, for example, and also the hand hygiene medicine every time for the patient. But actually, it's really cannot maximum or maybe it's not optimal to do it, because of course when we have to reduce the risk of the infection, it means that the facilities, the resources must be available also. But if it's not, we cannot do as much as we can sometimes. But we try to do the best. Is that
Yeah,
any other, Linda?
that's all. Thank you, Miss Henrik, for the information.
Okay, thank you.
Okay, thank you, Dinda, for quite such a very interesting question. Okay, so this is the end of our first session, and I would like to express our gratitude for Miss Henny for this such a wonderful answer and sharing the knowledge for us. Yeah, and then I would like to express my gratitude also to Mas Nazmi, Mbak Mega, Mbak Hafida, dan Mbak Dinda about the actively join this interactive session. And then before we close the first session here, it will be a certificate for Mrs. Hennig, philosophical doctor, and for her lecture this morning. Congratulations, Miss Hennig.
Thank you very much, Mrs.
You're
Rita.
welcome. Okay, so this is the end of our first session, and I will return this screen to Miss Olivia. Time is yours.
Okay, thank you, Mrs. Sari and Dr. Hani Tri Rahayu, PhD, for giving us such informative and wonderful presentation. Before we move to the next material, we have 30 minutes for resting, and all participants in here must be back online again in this Zoom at 9:30 a.m. to join the next lecture from Professor Kesinik Chotivanik from Mahidol University. So, dear participants, you can take your time for resting and see you later and good morning. And don't forget to come back again in this Zoom at 09 and 30. Baik, adik-adik, sekarang kita bisa istirahat dulu sebentar ya. Nanti silakan kembali lagi pada jam 9.30. Tidak usah left Zoom, tetap di sini saja. Kalian bisa istirahat terlebih dahulu. Okay, thank you everyone.
Loving can hurt. Loving can hurt sometimes, but it's the only thing that I know. When it gets hard, you know it can get hard sometimes. It is the only thing that makes us feel alive. We keep this love in a photograph. We made these memories for ourselves, where our eyes are never closing, hearts are never broken, time's forever frozen still.
So you can keep me inside the pocket of your ripped jeans, holding me closer till our eyes meet. You won't ever be alone. Wait for me to come home.
Loving can heal. Your loving can mend your soul, and it's the only thing that I know. I swear it will get easier. Remember that with every piece of you. And it's the only thing we take with us when we die. We keep this love in this photograph. We made these memories for ourselves, where our eyes were never closing, our hearts were never broken, and time's forever frozen still.
So you can keep me inside the pocket of your ripped jeans, holding me closer till our eyes meet. You won't ever be alone. And if you hurt me, well, that's okay, baby. Only words bleed. And inside these pages, you just hold me, and I won't ever let you go. Wait for me to come home.
Wait for me to come home.
Wait for me to come home.
Wait for me to come home. Oh, and you can fit me inside the necklace you got when you were 16, next to your heartbeat where I should be. Keep it deep within your soul. And if you hurt me, that's okay, baby. Only words bleed. Inside these pages, you just hold me, and I won't ever let you go. When I'm away, I will remember how you kissed me under the lamppost back on 6th Street, hearing you whisper through the phone. Wait for me to come home. You must think that I'm stupid. You must think that I'm a fool. You must think that I'm new to this, but I've seen this all before. I'm never gonna let you close to me, even though you mean the most to me. 'Cause every time I open up it hurts. So I'm never gonna get too close to you, even when I mean the most to you, in case you go and leave me in the dirt. But every time you hurt me, the less that I cry. And every time you leave me, the quicker these tears dry. And every time you walk out, the less It's sad but it's true, I'm way too good at goodbyes. I'm way too good at goodbyes. I know you're thinking I'm heartless. I know you're thinking I'm cold, but I'm just protecting my innocence. I'm just protecting my soul. I'm never gonna let you close to me, even though you mean the most to me. 'Cause every time I open up it hurts. So I'm never gonna get too close to you, even when I mean the most to you, in case you go and leave me in the dirt. But every time you hurt me, the less that I cry. And every time you leave me, the quicker these tears dry. And every time you walk out, the less I love you. Baby, we don't stand a chance. It's sad but it's true, I'm way too good at goodbyes. I'm way too good at goodbyes. No way that you'll see me cry. I'm way too good at goodbyes. No, 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 no. No way that you'll see me cry. I'm way too good at goodbyes. 'Cause every time you hurt me, the less that I cry. And every time you leave me, the quicker these tears dry. And every time you walk out, the less I love you. Baby, we don't stand a chance. It's sad but it's true, I'm way too good at goodbyes. Red cups and sweaty bodies everywhere, hands in the air like we don't care. 'Cause we came to have so much fun now. Got somebody here, might be the one now.
If you're not ready to go home, can I get a hell no? 'Cause we're gonna go all night till we see the sunlight, alright.
So la-da-dee-da-dee, we like to party, dancing you and me, doing whatever we want. And this is our house, and this is our rules, and we can't stop, and we won't stop. Can't you see it's we who own the night?
Can't you see it's we who about that life?
And we can't stop, and we won't stop. We run things, things don't run. We
don't take nothing from nobody.
Yeah, yeah.
To my homegirls just trying to live it up, shaking it like they can't get enough. Remember, only God can judge us. Forget the haters, 'cause somebody loves you.
Memories made till the night's through, surrounded by the ones who love you. We all so turned up here, getting turned up, yeah.
So la-da-dee-da-dee, we like to party, dancing you and me, doing whatever we want. This is our house, this is our rules,
and we can't stop, and we won't stop. Can't you see it's we who own the night?
Can't you see it's we who about that life?
And we can't stop, and we won't stop. We run things, things don't run. We don't take nothing from nobody. Yeah, yeah. It's our party, we can do what we want to. It's our house, we can love who we want to.
It's our song, we can sing if we want to. It's my mouth, I can say what I want to.
And we can't stop, and we won't stop.
Can't you see it's we who own the night? Can't you see it's we who route that light?
And we can't stop, and we won't stop. We run things, things don't run. We don't take nothing from nobody. Yeah, yeah. It's our party, we can do what we want to. It's our house, we can love what we want
Can't you
to.
see it's we who own the night? Can't you see it's we who route that light?
It's our song, we can sing if we want to. It's my mouth, I can say what I want
We run
to.
things, things don't run we.
'Cause we can't stop. Heart beats fast, colors and promises. How to be brave? How can I love when I'm afraid to fall? But watching you stand alone, all of my doubt suddenly goes away somehow. One step closer. I have died every day waiting for you. Darling, don't be afraid. I have loved you for 1,000 years. I love you for 1,000 more. Time stands still, beauty in all she is. I will be brave, I will not let anything take away what's standing in front of me. Every breath, every hour has come to this. One step closer. I have died every day waiting for you. Darling, don't be afraid. I have loved you for 1,000 years. I love you for 1,000 more. And all along I believed I would find you. Time has brought your heart to me. I've loved you for 1,000 years. I love you for 1,000 more. One step closer. One step closer. I have died every day waiting for you. Darling, don't be afraid. I've loved you for 1,000 years. I love you for 1,000 more. And all along I believed I'll find you. And time has brought your heart to me. I've loved sound closer.
Oh, thinking about all our younger years. There was only you and me. We were young and wild and free. Now nothing can take you away from me.
To our participants from Malaysia, Thailand, and Indonesia and Philippines, in a few minutes, we will start our Nursing International short course, second material of today. So please turn on your camera during the event and pay attention. Thank you very much. Okay, good morning, everyone. I would like to welcome again to our speaker and audience from Indonesia, Thailand, Malaysia, and Philippines. To the honorable our guest speaker, Professor Kesini Chotifanik from Mahidol University. The next agenda is second lecture of today from Professor Kesini Chotifanik from Department of Clinical Tropical Medicine, Faculty of Tropical Medicine, Mahidol University, Thailand, by the title Treatment for Anti-Malarial Drugs Resistant Plasmodium falciparum Malaria. And in this morning, the material will be moderated with Mrs. Juwita Sari, Master of Science. To Mrs. Juwita Sari, time is yours.
Thank you very much, Miss Olivia, for the opportunity. Good morning, Professor Kesini Chotifanik. Hello. It's very nice to me to greet you this morning. Thank you very much, Professor. So before the sharing material session, let me introduce our second speaker, Professor Kesini Chotifanik. Professor Kesini Chotifanik graduated from Faculty of Science, Mahidol University for her degree of Doctor of Philosophy, Pathobiology. And in 1998 until 2000, postdoctoral of the Wellcome Trust Mahidol Oxford University Tropical Medicine Research Program in Bangkok, Thailand. And her current position as professor and head of Cell and Tissue Culture Resources Unit, Department of Clinical Tropical Medicine, Faculty of Tropical Medicine, Mahidol University of Bangkok, Thailand. And then she as Deputy Dean for International Relations and Networking, Faculty of Tropical Medicine, Bangkok, Thailand. She also became the Deputy Director of Southeast Asian Minister of Education Organization, or CMO, TropMed Thailand, and Associate Fellow of the Academy of Science, the Royal Society Thailand. At least Professor Kisine already published more than 135 articles in very good reputable international journals. So before the presentation begins, let me inform how the presentation will be going on, Professor. The first, you will be invited to present the material, and after that, there will be question and answer session. And now allow me to welcome the speaker, Professor Cassini, to deliver her presentation about treatment for antimalarial drugs resistance Plasmodium falciparum malaria. Professor, time and screen is yours.
Thank you very much and good morning, everyone.
You're welcome.
So let me
Good
share
morning.
screen first. Okay,
Okay.
should be this share. See the slide? Let me make a big one.
Yes.
Okay. Is that full screen?
Yes, already in full screen. Thank you.
Okay. Thank you very much for the very nice introducing me. Thanks for the MC and special thanks to Dr. Kernia, who is the coordinate with me and also invited me as a speaker. Again, good morning, professor, lecturer, students, ladies and gentlemen. Morning from Thailand. Nice to meet you all. And it's my honor to be your invited speaker for the Nursing International short course. Before we start, since we are on the 5th, so Happy New Year to you all and wishing you all happiness always. We are from Faculty of Tropical Medicine. You see our hospital building on the left. And in my lab, which is the Malaria Laboratory in Department of Clinical Tropical Medicine and Maiden Oxford University research programs. And we are here and I'm on behalf of them to say hello to you, okay? Before we start to talk about antimalarial drug resistance and what is the new treatment, I think it's better to have one slide to remind or recall all of you as a student. I'm not sure how much you remember about malaria. Malaria is the parasite, right? And erythrocytic intracellular parasites. And they use different two horses. And malaria, which cause disease in human, is Plasmodium species. And you see, I'm listed here. Yeah, in the past, we talked about 4 human malaria species. And now we have malaria the 5th, Plasmodium noci or norici, which is the zoonotic, is the Plasmodium from monkey to human. But for today, we will focus only the first one, Plasmodium falciparum, which is the most malignant malaria because it's called cerebral malaria, complicated malaria, and severe malaria. Okay. Look at the left hand, just to remind you a little bit about the life cycle and just recall you how we get malaria infection. Start from the mosquito. So Anopheles mosquito is the vector for malaria. And once they bite to the human, they release the sporozoid, which is one form of malaria parasites in their salivary glands to the humans. And from after the inoculum, the sporozoid will go to river. Okay. Number 2, in the liver cells, they will grow, in the hepatocytes and multiply from 1 to maybe more than 100, okay, and make the hepatocyte rupture. And once the hepatocyte ruptures, the malaria parasite will release back to the blood circulation and looking for the new home, which is the erythrocyte, okay? And from the young stage, after invasion, we call ring form because it looks like the ring. They're growing up to trophozoite and multiply to Chison stage. So that's why the number of malaria parasite will increase from very low number to the high number, that what people call parasitemia. Okay, higher number, more severe. Okay, and after they increasing more and more number, some of them will change to the sexual stage, what we call gametocyte. Okay, that you might heard about banana shape. So which stage of the malaria parasite cause you sign and symptom and get people sick? This one, number 3, erythrocytic stage. So you know sign and symptom, fever will have, patient will have fever, have myalgia, nausea, vomiting, which is all are non-specific. It look like flu, get like other infections, okay? For gametocyte stage or banana shape, this is not pathogenic state, not give you sign and symptom, but it is important for transmission. This form will waiting for the mosquito bite and taking the gametocytes to grow in the mosquito, develop to sporozoid in salivary gland, and waiting for the next inoculation or the next bite, get more new malaria cases. So this is complete of the life cycle. So what about the time and duration of the life cycle? For Plasmodium falciparum and vivax, it takes 2 days, which is 48 hours. Malaria 3 days, 72 hours. Ovaria 24, and no sign just 1 day. Okay, 24 hours. Why we have to know the duration? Because after they complete the life cycle, like falciparum, which we're going to talk today, it needs 2 days. That means after the red cell rupture, is released monocyte from Chison looking for the new red cell for invasion. It will release malaria toxin and many other substances which activate the cytokine in our body and cause fever. Okay, so as the nursing cares, when you look at the temperature record, you will see the pattern of the fever. Not every day, every 2 days, 3 days, it depends on the species. Okay. So as I mentioned, if we cannot differentiate the malaria infection with other disease by sign and symptom, we definitely need the laboratory tools to do the definite diagnosis. Please look at the right hand side. You see the blood film. After we did the blood smear and stain it, and you will see something inside the red cell, right? This is the malaria parasite, and the species is Plasmodium falciparum. Okay, and at the lower photo, you will see gametocyte stage, male and female gametocyte, which is important for the transmission. Okay, so one slide to remind you about malaria parasite. So we move to the next one. Now, we are all in the malaria elimination era. World Health Organization have announced for in the world, many countries to have the same target, what we call malaria elimination, get rid of malaria, try to make the zero in the country, especially in the malaria endemic area. Okay, so please do not worry about this slide. It looks complicated, but actually it's very good slide to summarize you that the World Health Organizations have the strategic plans and register many countries through malaria elimination programs, and they aim to get the zero malaria by 2030. Okay, and in the components, they have many strategic plans, not only treatment, also vector control, prevention and control, protect the malaria resistance, and also the future plan, how to maintain the zero malaria in the future. Okay. And what is the key things that I would like to introduce you is here at the under the pictures. From the latest report from World Health Organizations last year, just passed, right? They reported that number of malaria cases is going up, I mean increase during the COVID-19 pandemic. So there are many reasons, as you know, during the pandemic, it's difficult to operate the control, prevention and control program. And also we have to face with the obstacle a lot during the first attacks by the COVID-19 infections. So, and number of the budgets that we have to allocate to COVID-19 infections. So with the limited facility budget and the manpower, that's why the number of malaria cases is increased. So this is the alarming to us, and look what the rationales behind, what's the background of that. Come and read courses by country, you know, what they report. Just start from the first of the world map. The red color represents the country which still have malaria cases. What they call the indigenous cases, that means transmission within the country. Exclude the imported malaria. Imported, that means travelers come back from others after traveling and they get malaria infections. So this is what they call imported malaria, right? But for endogenous, that means they get the vectors and get the new cases within the regionals or in the country. So you see Thailand, my country, and also Indonesia, Malaysia, is still labeled as the red color. We still have malaria cases, and some, the blue color is the zero cases for more than 3 years. So those countries have been certified by the WHO as the malaria elimination successful. Okay, go to the left-hand side, the below graph, the right graph of the case report by Thailand. In my country, we still have the number of cases and a little bit, maybe 1 or 2% increase during the COVID-19 infection, especially for the zoonotic malaria, which is Plasmodium knowsi. Okay, so we have to refresh all the program and activate and have the training of the special group as well to make it more effective. The key thing is have to be detect the new cases immediately to stop the spreading. Okay. And what about on the bar graph on the right hand? This is from the WHO report from Indonesia. You can see the number of cases is about 100,000. Okay, so that means malaria infection is still our problem, especially in the tropics area. One of the key strategic plans or strategic program is about anti-malaria drugs, okay, which we're going to give you in a little bit more detail about the resistance. In this slide, I show you many anti-malaria drugs that we use in the class and at the present, okay? And by categorize them by their function, how they kill malaria parasites. So we start on the right hand, what we call sporocidal drugs, which can kill sporozoites. So there are about 2 or 3 drugs, okay? And we have the gametocytocidal drugs. We shown it here. So the main actor is the primaquines and tafenoquines. We also have the drug which can kill the malaria parasite in the liver. Okay, and the left hand is the many drugs which can kill parasite in the blood stage, which is when the parasite in the erythrocyte. I will show you what is the main regimens at the next slide for malaria treatment and what is the problem. This gives you an overall or the clue of anti-malaria that we have at the moment. What about the efficacy? That means what the outcome after treatment of all those anti-malaria drugs. This slide is very popular, okay, because our Professor Nicholas White, will be based in the Maidstone University and Oxford University, have presented in many reports and also publications about the cure rate in falciparum malaria when people use in the past to 2000. Start from the left hand, okay? The y-axis is percent of the cure rate. So definitely we prefer 100%, right? And the x-axis is the year. Start with the CQ. CQ is chloroquine. When CQ first introduced for malaria treatment in 1975, after a few years later, they got the chloroquine resistant. How we know that? Because the percentage of the cure rate dropped to 10%, which is not good. Similar to sulfadoxine, pyrimethamine, and also M is the mefloquine. Okay. What about the conventional or traditional treatment, as you know, as the quinine or quinine? Okay, quinine give the 100% cure for many years, but after that one is dropped to 80%. They will use tetracyclines to combine to achieve 100% cure rate. Okay, so quinines have not reported directly about the resistance, but since they have the effect only to the mature stage and take a long time, to get to the therapeutic level, and also the side effects a lot. So that's why people or scientists, physicians and researchers need to get any other drug we have rapid action and can kill all the stages of malaria parasite. Okay, AM is artemether and artesunate, which introduced after 1990 and get very good cure rate. Okay, this is the history. So now we go to the what we have now. Okay, as I mentioned, I'm not sure anyone known about the artemisinin and artemisinin derivative, which have been introduced after 2000 as the anti-malaria treatment, what people call the artemisinin-based combination therapy, okay, ACT. This recommended by WHO. Why they introduced artemisinin? Because this drug will have very rapid action, okay, and have broad stages of effects to malaria parasite. Artemisinin can kill young stage and mature stage, which is good because we don't know when patients come in to see clinicians or physicians what is stage of the parasite. So if we have the good tools or good drug can kill all, that's perfect. Okay. Another thing is the rapid action. Okay. The level increasing in the blood within a few minutes and kill all stages, which is perfect, but still have some limitation. Why? Because it is rapid actions where the clear from the vaccination is also they're going down rapidly as well. So that's why the regimens that recommend to treat, they use the anti-malaria drugs as the combination. Okay, this is the list that I give you for artemisinin drugs. There are many names. Artesunate for injection, intravenous, artemether for intramuscular, dry hydroartemisinins, which can in the pre-package at the pack I show you later, and artemisinic acid, artemethyl. So these are the artemisinins. The mechanism of action people talking about here, the what they call the double bond between the oxygens bridge is here, which very rapid oxidizing, and they can, after oxidizing, they get the free radical, which can kill the malaria parasite. Since they have rapid action and also the short half-life, so they have to combine, okay, with other long-acting drugs. So this is the anti-malaria drug combination therapies that we recommend. That you see there are many formula, okay? Start from the pre-packaged, combine two drugs together, and you can get as the commercial products or commercial drug like Uratisin, Paramax, Coartem, Articoms, and also can have the separate, okay, give artesunate and mefloquine, artesunate, sulfadoxine, pyrimethamine. So after World Health Organization introduced the ACT for malaria treatment, we get the good cure rate and efficacy for a few years till 2015. What happened? Okay. This show you as the how artesunate or artemisinin derivative is superior to quinine is based on the research which have been published in Lancet before introduced to policy maker and make the guidelines. Our teams, you see here, our professor is one of the key persons for this policy. What happened? After that, we have the report, okay, from multi-center trial study, both in Asia, in Africa, to saying that there are some patients who receive the ACT have the prolonged parasite clearance longer than 5 hours, which is strange. I mean, it's not it's abnormal. Usually, after you give the drugs of the ACT to the patients, the parasite clearance go down by half within 1 to 2 hours. Okay, so when you have get the report from many countries, which all need the strong evidence and documents. So Faculty of Tropical Medicines perform the multi-center trial, which is very big, what we call track 1, to look at that and provide the evidence. It's true, right? Here in the map from the track 1 study, the red color show the percentage of the cases who get the prolonged parasite clearance after ACT treatment. Okay. So after this paper is published and they were investigated by the expert, WHO get the what we call the containment, start trying to keep the resistance within the area, not spreading to the others. Okay, because in the past, once they start the resistance, especially from Southeast Asia, the malaria parasite, carry the resistant gene to spread out to African country and make the problem. Okay. I like this map and I would like to give to you because in Nature Review Microbiology, they summarize drug by the actions that what we use for anti-malaria on the right hand, and they also get the map for the chloroquine resistant and sulfadoxine resistant. That means you cannot use those drugs in those countries, and also the green colors for artemisinin resistant. So once the artemisinin resistant is happened, what we have to look at that, any other drugs can be introduced. Do we have any new drugs ready to use? And what about the vector control? Can the mosquito carry the resistant malaria parasites to get to other cases and spreading, which is make you the headache and difficult. And anti-malaria resistance is the main obstacle to get the malaria elimination. Okay. And what about the malaria parasite itself? What the mechanism? Malaria parasite is very clever. They have mechanism to resistant to anti-malaria drugs, as I show you. After introduce a new drug, especially for synthetic drugs for a few years, they become resistant quickly. There are many mechanisms that I will talk about it later. Okay, and this is the one from the publication in 2017, just to show you that after chloroquine and fancida introduced, it's spreading, and usually it's come from Southeast Asia to the others. So the key thing is that we need to drug that stop the spreading of artemisinin resistant. It can be the old drug, but different regimen, different formula. Okay. So now, how we detect the malaria resistance? There are 3 models at the moment. The first one, you look at the efficacy in patients. People, especially our job as the nurses, we have to look at the fever clearance time. So if the drug effective, the fever should be gone, right? After patient receive the treatment. So when you look at the temperature plot, in temperature plot chart, have to look to it carefully. If the fever prolonged, that means the drug not effect at all. You have to report and consult other staff and report to the doctors, physician. Another thing is the parasite clearance time. This is also important. We will get the data from the laboratory, right? From the hospital labs. We have to look in that the pattern of parasite is going down or not. If not, what happened? Have to consult and notify to the team, okay, to save our patients. So what else? What other tools to look at the resistant parasites? We have the laboratory test, okay, but maybe not every hospital, but different laboratory in the hospital, I think they can do it. You can send and ask for the laboratory test to check whether why the fever is still not going down and parasite clearance is very prolonged. We might have to check the resistant pattern of the parasite, like what is similar to you send for the MIC for the microbiology lab, okay? And the third one, the tool is molecular approach. People might study using the molecular techniques to look at the gene of the mutation of the parasite to see whether it's resistant or not. And for artemisinin resistant, people talking about the KELCH or K13 mutation. I'm not go through in the detail in this lecture, okay? But just mention if you heard from other people to talk, for artemisinin resistant, they will talking about the K13 mutation, KELCH mutation, which make the parasite less susceptible to artemisinin, particularly for the ring stage, the young stage. This chart, right? I mentioned, look at the artemisinin, PF-cal or cal13 mutation is one of the problem or the mechanism of the resistance. And other molecular marker that people use to prove the malaria parasite, but unfortunately, molecular techniques, you need a lot of expertise and tools and also expensive. So it might not good to go to the field, to the hospital in endemic area, but in lab will use, and also researcher as the research will use. Why we have to know? Because if we know, so we can look at the target for the new drug and also prevent them to spreading out. I show you here what the laboratory tests that people use to detect artemisinin resistance. Why we need the new technique? Why don't we use the conventional techniques we recommend by World Health Organization? Because the conventional techniques, or what we call 48 hours, cannot detect or differentiate the artemisinin resistant parasite at all. As the reported in 2009 on the left hand, when you look at the parasites with resistance with the red dot, with the sensitive one in the blue dot, you see the 50% inhibition concentration or the drug level of the drug which can kill parasite by half is no different between resistant and sensitive one. But what our faculty, when we get the questions from the malariologists, how we detect that, we use develop the new techniques, what we call 24-hour test. Need only 1 day to check it. You get the good correlation of the 50% inhibition concentration with the parasite clearance time. That means if the dot spreading to the right hand, you need more drug to kill parasite. That means it's resistant. Okay, so if they get very low concentration of the drug on the left hand, that means they're very sensitive. Okay, so by this technique, you can split the parasite to at least 2 groups, which can kill 50% of them die when you introduce less than 5 nanograms per ml. And if more than that, which spread to the right hand, that means you need more drug to kill. It is resistant. Okay. For your update information, and this is very updated one. That's how people detect resistance. What about the treatment? Okay. So after track 1 and track 2 finish, we confirm that there is artemisinin resistant parasite. So how we make the containment, that means stop the spreading and also save our patient. Okay, about the new regimen. Since we have no new drugs ready yet to pick up and give to the patients, so our group at the Maidon University and Oxford University recommends what we call the triple therapy. Instead of using 2 drugs, it will be 3 drugs, okay, to combine, which I'm going to show you here on the right hand in the pictures, right? With dihydroartemisinin, piperacin with mefloquine, add up mefloquine, or add up with amodiaquine, okay, and see the difference. And the good news is that after this study finished, we found that the triple therapy is significant difference on the parasite clearance time and filarial clearance time, and good for the patients to have the receive the triple treatment. But what the limitation? The limitation is not all these drugs will be available in all countries. We have malaria cases, okay? So For example, here, dihydroartemisinin and piperacillin, which now in Thailand by the country policies, our Ministry of Public Health also recommend these drugs for our malaria patients. Okay. If there is the resistance, we recommended to add up with the mefloquine. However, this drug might not available in other country as well. Okay. And as you know, dihydropiperacillin also already reported resistance in my country at the Thailand-Cambodian border. So we have to switch to other drugs. Okay. This is very good slide for your information. What happened with all the anti-malaria drugs after introduced to use as a treatment when they start to resistant, and how people report and stop it. Okay. So what's the option? What to do next? We need the future anti-malaria drugs. Unfortunately, it's still on the clinical trials. I will explain you what the way to get the new drug is quite long. You need very long time. Okay. And how to containment, that means stop spreading of the anti-malaria drug resistance. You probably need the transmission blocking drug, right? Transmission blocking drug, that means you kill the gametocyte. So not allow them to pick up the, bite the patient who get resistant parasite and carry the parasites to another new cases. Gametocytes is the sexual blood stage. Okay, as I mentioned, it's not give you sign and symptom, but important for transmission. So many people try to study how to kill gametocyte. This slide give you the stage. Gametocyte have 5 stages to development, but if you see in the patient blood, it will be mature stage, stage 5, which is here, which I say banana shape. So there are many studies conducted how to kill these gametocytes. Good news, we still have one drug at least to give to the patient to kill gametocytes, what we call primaquine, right? You might heard about this at 0.5 milligram per kilograms for uncomplicated falciparum malaria, just the single dose to kill gametocytes, and then followed by with the ACT treatment. And this is the drug in the pipeline for malaria. And you know, once scientists discover new drugs, they have to test before they go to the market, which might take about 10 years, 15 years, it depends. Okay, this is the list of the pipeline. You can see a little bit more detail if you're interested in the MMV website. Go to the Google and type MMV, so you got it. Before we go to the new drugs, I'd like to summarize for you a little bit how we get the new drugs, okay? So usually, as the scientist, as what I can do for the new drug is what we call preclinical testing. You can test in the laboratory, or you can test in animal if it's needed. And after you can see the activity, the next step, you have to prove for the safety and toxicity of those drugs, what we call the preclinical trials. In the preclinical trials, you might need not many cases of the patients or the volunteer, which is no malaria. to check whether what is the dose is suitable to introduce in the human body. And then you can go to clinical trial phase 1, 2, and 3. The difference, I won't go to in the detail, but briefly, phase 1, go to the healthy volunteer, which is no malaria. Phase 2, it can be 2A and 2B to test the drugs with the patients uncomplicated, plus with maybe in the severe cases. And phase 3, get the bigger sample size, test more cases, and see the efficacy and outcome, and also the side effect. And after that, before you go to the market, you need to get the final data analysis proof by the FDA or by others, the authenticator. And also after that, you have to go to the market and go to the surveillance before you can introduce as the routine treatment. So you see, it's quite a long way to go. Very, very long. For malaria, we have 3 new drugs, okay, which have already published and tests for the efficacy, tolerability, and pharmacokinetics, what we call phase 2A and 2B. As you notice that it still have the code as the number like OSAS 439, KE 609, and KF 156. I go one. So for OSAS 49 is from the medicine formula venture who discovered this drug. It's the second synthetics, right, with the second, first and second generation. Why they try to produce OSAS 49? Because artemisinin is a short half-life. They change the side chain to other group and try to make it longer half-life. If it's longer half-life, that means the drug can affect more, right? More get higher efficacy. So another 2 drugs is from the Novartis. They discover what we call spironolactone and imidazopyperazine. They claim, they reported that these 2 drugs can kill both blood stage, malaria parasite, and also at the gametocytes, okay, and at the liver stage. And not only falciparum, there are also effects to Plasmodium vivax as well. And these slides summaries what the latest information for these 3 new drugs is good clinical response, no serious adverse effects, no serious side effects, and can clear the parasites rapidly, which is good, right? And they already proved that it can affect to both falciparum and vivax. So now they move to phase 3. I give you one additional new compound. We still say it's compound because it's still under developing to let's say to show you that we still have a new drug on the pipeline for malaria, which is we call P218. This is from NASDA, which is the National Science Technology Agency from Thailand. They developed these drugs with the action which we call Plasmodium dihydrofolate reductase inhibitor or DHFR inhibitor, but still on the phase 1 trials. This is the slides, give you the summaries, the activity of anti-malaria drugs, the one that we recently used, and the new one, I mean the comic ones, they talk about the effects at different stages. I think it's a good slide to summary. Just in case you would like to come back and have a look what what the actings or the action of those drugs. Okay. Last 3 slides that I would like to emphasize you is about the key message from World Health Organizations. All of my talk today, you can go back and have a look of the reference from the World Health Organization guideline for malaria. We see the latest one is November 2022, right? I mean, only 2 months ago. And you can get PDF file when you go to the virtual website. My last slide will give you the link. Okay. What they mentioned. First thing, malaria need the early diagnosis and treatment. Why? To protect patients develop from uncomplicated to severe malaria. That's the first thing, right? And the second thing is to reduce the transmission, especially for the one that have the artemisinin resistant or antimalarial drug resistant parasite. Okay. Number 2, since you have to do early diagnosis, so you need the diagnosis, the what do you call, the powerful and the facility to diagnose malaria. As I mentioned, you cannot use by sign and symptom, right? You need laboratory tools, at least microscopic examination to confirm. Luckily that we have the rapid diagnostic test, RDT, that we can use to check. It's like the pregnancy test. You just use the 1 drop and buffer, and you can see whether have the 1 band or 2 bands to get a positive malaria. And the third one is the treatment. People should use artemisinin derivative based combination therapy, ACT, to get high efficacy, high percent, 100% cure rate, and void for the resistant. Okay. And this is highlight early diagnosis, pick up the right drug to use, and don't forget to complete all the drugs. Some drug you need 7 days, 14 days, you need to complete it. Otherwise, you introduce the resistance, okay? And like antibiotics. And also, you have to be careful when you give the drug to the patient. And as nurses, you have to remember 4 R, right? Right person, right dose, right time, and right place, okay? And this is the reference that I mentioned. This is the most recent one, okay? For Health Organization, the new release is in November, and you can go this link if you would like to get more in the detail. I think now it's timing, 10:30, right? Thank you for your attention, and I'm happy to take any questions from all of participants. Thank you very much.
You're welcome, Professor. Okay, thank you very much, Prof. Kisine, for sharing the excellent topic about treatment for antimalarial drug-resistant Plasmodium falciparum malaria. And now we can move to the discussion and interactive session. So we give opportunity for all of you to ask several questions. It could be through chat column or could by live session, followed by pressing your raise hand button. So please, maybe some of you would like to actively participate in this interactive session.
Maybe yes.
Can I ask you,
Yes.
Professor?
Yes, of course. You can introduce yourself first.
Yes, thank you. Hello, my name is
Welcome.
Angin Raziza. I'm studying in University of Muhammadiyah Malang. So Excuse me, Professor, I want to ask how we deal with malaria, especially not only in Indonesia and in Thailand, because considering that the malaria risk is getting higher according to the data. And there are also some people who still don't know what is a malaria and how to deal with it. So thank you, Miss.
Okay, you're welcome. Professor,
So,
would you get the point?
so I think you would like to say how
to deal with malaria?
deal
Yes.
with malaria. Yes.
Yes.
As I mentioned, the key things for malaria elimination is have at least 4 domains, right? Malaria is not only parasites, not only people. It's also involved with the vector, mosquito, and it's also involved with the drugs, right? So let's come a bit close to, to you ourselves as the medical staff, or we are in the medical field. So we have to focus on our patients, right? So when we have the patients, you probably have to detect it early whether malaria or not. As the key things, you use laboratory tests, and you have to make sure that you don't miss any cases. And second, the treatments, patient need to get the right treatments and immediately, right, to protect, to develop to severe cases. And the third one, they have to 100% kill, not breath any parasite in the body. Otherwise, you have a chance to make the resistant and spreading to the others. And also, if they don't get the full course of treatment, they probably come back to you, to the field clinic, right? And the fourth one, education. You have to give them information how to protect malaria. We don't have any good prophylaxis yet, but the good thing is protect from mosquito bite. So health education is also important. How to prevent yourself to malaria, and information that if you the group of the risk, right, pregnancy, children, probably you should not travel to the endemic area. You can skip that trip or not. If not, you have to go with family. So you have to know that after 7 or 14 days, if you have fever, to think about malaria. And don't forget to give history of traveling to endemic area to doctor or nurses. Then I covered the questions. I think better to discuss the things that's close to you. Otherwise, we have to talk about the policy. We talk about the elimination programs, which is also important, but as in our group, I think this is the key message.
Okay, Professor. I think we get the point. How about Mbak Anggi? Is it pretty clear for you?
Yes, thank you,
about the
Professor.
answer? Okay, thank you. This is one more question, Professor, from chat column from Miss Andriani.
Okay.
If the person has ever had malaria, is there a possibility of being infected again? And if malaria attacks a breastfeeding mother, is there a possibility that her child will get malaria too?
Very good question. Thanks for your questions. Okay, start with the first one. Definitely yes. You cannot stop mosquito to bite, right? And very important is mosquito don't need any visa to fly between the country, right, across the border. So be careful. Don't allow Anopheles mosquito that reach in the evening, right, to bite you, right? Wear the long sleeve, long trousers, you use the repellent, it can protect. The answer is yes. When you get malaria, you can get malaria against and with different species or the same species. That's why we don't have malaria vaccine yet. Malaria parasite very clever to change our immunity, cannot remember or recognize them. Okay. And the second question, pregnant women get malaria, right? Yes, pregnant women get malaria, and you have to choose the drugs properly, right? Especially during the breastfeeding. And your answer is that malaria go to the baby or not? Yes. During pregnancy, there are many hypotheses saying that, as you know, actually, if the baby is in mommy is closed system, right? They get food and nutrients, oxygen through the placenta, right? And they have the fetal blood circulation and maternal blood circulation. But during deliver or labor times, there are lots of the detachment, right? And the blood, it can be mixed up. So we call placenta malaria and also malaria, neonatal malaria. Okay, so the answer is yes, it's possible the baby to get malaria if mommy get infection. Yes.
Okay, thank you for your answer, Professor. Pardon me, Professor. There's someone who would like to greet you this morning. Maybe, yes.
Okay.
Miss Anggraini Dwi Kurnia, please.
Hello.
Hello.
Nice to see you.
Good morning, Prof. Hi, nice to meet you. Okay, thank you, Prof.
Yeah. So
Thank you for joining this meeting. Yes, finally we can meet in person, even
yes,
in the
yes,
virtual
we email
meeting.
a lot.
Yes, after,
Thank you.
yes. Sorry for disturbing you, Prof.
Oh,
And
no,
thank you
it's
very much.
okay.
Okay.
I'm
Okay,
happy to help.
after
Yeah.
previous email.
Yeah.
Okay, so right now we can
Yes.
see you here. Okay.
But Kania, I just
Yes,
noticed
Prof.
that you don't have
Mhm.
only students from Indonesia, but also from Malaysia, from IMI
Yes,
as well.
yes,
Yeah.
Prof.
Yeah.
Yes, Malaysia and
Yeah.
Thailand also, and
Ah,
Philippines. Yes. Okay, so
okay.
it's
Nice to
not
meet
only
you
in
all.
Indonesia.
Sorry.
Yes, Prof.
Yeah, I
Okay.
didn't mention about
Nice
it.
to meet you.
Otherwise, yeah, I will get lots of graph of all country for you. for the for the malaria report.
Yes.
Okay.
Okay, thank you. Okay, Prof, I have one question for
Yes.
you regarding for the community setting, Prof. Maybe you have some experiences how to best practice to prevent the I mean that to block the malaria transmissions, particularly in the place that have high the malaria prevalence, Prof.
Yeah.
Thank you.
Okay. Thank you.
Okay. Thank you, Prof.
Okay. So let's start from vector, which is the easy one. There, I mean, I think all country, right? We have the vector department control. So they tries to survey, okay, the vectors, because malaria need the mosquito to transmit, and also with the control, monitor and control. That's part of vector. For our role as the scientists, right, we get lots of questions from the field, from the community, right? Why the number of cases is going up? Any resistance? Or are they changed? There are any mutations? So that's what the researcher and scientists do. Can we detect malaria parasite by other techniques which is more powerful and quickly? Something like that. So that's why in the community, people use RDT, rapid diagnosis test, to detect the new cases. This is important in community. And I think the volunteer in community and also the healthcare person, they can use this tool immediately, because it's like the COVID-19 test and PrEP test. Just one drop, right? And then test whether one band or two bands. If it's two band, you have to go to the health center to receive the drugs. Because if you cannot detect any early cases and you have the vector there, definitely you get the new cases. So community will be learned some the primary health care as well. And the third thing is about the medical and what was the doctor and physician nurses team. You are very important because you are the one who close to the patients. So the first alarming to us to say anti-malarial drug resistance is from you and your team, because you notice that, why fever is still on day 3, day 4, day 5, something strange, something happened, right? And also the parasite clearance time is longer. That's alarming is come from your end, which is important. So we have the team, we need a good team to prepare for malaria, not only one stop at the community, but also in reference hospital, university, and also the team. I answer your question?
Yes, Prof. Thank you. Thank you very much for your answers. Thank you.
Okay.
I will bring back to Miss Juwita.
Okay.
Okay. You're welcome,
Okay.
Miss Nia.
Right.
Okay, maybe furthermore, after here Miss Nia asking, I would like to ask you also, Professor, because in Indonesia, in the promotion and prevention, the most program from our government is mostly about dengue. Yes, because we still rare to hear the government approach to primary prevention about malaria. Is there any abbreviation or program that maybe we can create more to successing the program to reduce the malaria? For example, how to choose the insecticide or something chemical that may be match for against this kind of mosquitoes. Thank you.
Okay, thank you. For malaria, it's different for dengue from dengue.
Yes.
Because dengue is from the in town, right? But malaria, you
Yes.
have to go to the forest because vector is different. Okay.
Yes.
Okay. So for malaria, since vector is not in town, it's over there. In the past, people use DDT, impregnate bed net, but we stopped using it because it's resistant.
Oh.
And then we found that DDT is very toxic to environment as well. So they changed to pyritons and other things and herbal. I think it's good to provide them the impregnate bed net. So bed net we have coated with the insecticides, but the problem is they have to use it. I have experience, go to the field, they have the bed net. Everyone got the bed net, but they don't use it. Okay.
Oh,
so
okay.
the thing is the health
yes.
education. We have to inform them and make them consider and realize that they have to use it, right? And how to use it as well. Okay. And in terms of the policy, I think our MOPS, not only in my country, in your country as well, tie a lot to come a bit closer and make the real actions and activate all the activity at the same time. So I think what you call the people who stay in the area which have endemic area is very important. You need the group of volunteers or the one who keep and to talk as the or the
Something
leader,
like
leader
awareness
of
group.
villagers. Yes, and
Okay.
awareness. Yes. Important.
Okay.
Yeah.
So we cannot use DDT anymore because the bad impact of side effect using DDT in the environment. Okay, thank you. Is it very clear, Professor? And then we move to the chat column again. Their next question from Miss Hannah. How to handle malaria in your country? If this case occurs in poor people who have difficulty in paying fees. Thank you, Miss.
Okay. Malaria is disease of the poor people. You are correct. Okay. Not like cancer. Because if you talk about cancer, you have lots of drugs. They develop quickly because they have the target to use. and people can afford that. But for malaria, it's neglected diseases. I agree with you. So in our country, malaria is still the problem. And if we not control, we not support them, they become a problem, big problem, but because it will affect socio-economic, especially at the border. And you know, not only the border, if you get the malaria and not control them, it can spread across our country from the east to the west and go to other country as well. And people aware that because they don't want to get the one that resistant from Southeast Asia. So I think my answer is we list the malaria, although it's neglected, to be on the top 5 or top 10 priority. That's why the government announced malaria elimination program, zero malaria 2 years ago. But since we faced with the pandemic of the COVID-19, it's a bit delayed. Every country is delayed, okay? So now we come back to normal situation. All the group and the party is very active for that. So not only the policy, I think the operation team is very important as well. That's what my answer. And patients and people who are at the endemic area, they are ready for us to help and give the information. And I think all the facilities and support should reach them directly. That's the key things. Okay. What about in Indonesia? Maybe you can share with me, and in Malaysia as well. I think malaria is still your problem, right? And also you get the malaria resistant, same as in Thailand. Maybe different species, I'm not sure. Indonesia, maybe vivax. I see some report about vivax, severe vivax.
Yes.
Yeah.
Yes. Maybe maybe before my colleagues answer your question, Professor, actually in the west part of Indonesia, there are still rare cases related with this malaria, because when we heard about malaria, it's common in the eastern part or in the middle part of Indonesia. So when I read some evidence-based, we still focus on the malaria classification, such as malaria tertiana or something like malaria quartana, and how to choose the proper antibiotics or something like drugs to cure them. Because when several people go to the eastern part and then move to the western part of Indonesia, and they are already detected with the positive condition with malaria, it is become the very worst, because in the primary care unit we already lost the progress before. So maybe the problem is how to prevent the travel history of our patient, and how to make maybe algorithm regarding the type of or classification of the malaria, so we can make a nursing care plan better, maybe something like that.
Yes. Thanks for
Yes.
all
Thank you.
information. Very nice. So diagnosis is important, because if you cannot say what species, you will not know, because we have 2 species, you need to give the drugs to kill the hypnozoids, right? Otherwise you get rid. I haven't touched to that because it's the vivax malaria and oval. But for falciparum is okay. You don't get any relapse.
Yes.
Yeah.
And then this is one question from the students from University of Thailand, Professor.
Yes. Yes. Go ahead.
The name is Pakarin Srina Hariwirut.
ค่ะสวัสดี
Okay.
ค่ะ
Okay. He asked if a pregnant woman is infected with malaria, is there a high risk of a baby?
Yes.
Yes.
Malaria in pregnancy is one of the topics, and pregnancy, as you know, is the risk group for everything. High risk to get infections, and when they get infection, they probably get complication, right? The effects of malaria to the baby is the first thing is that the first trimester is might cause the abortion, and after that, if you get infections, there may effects to the baby by get the low birth weight or premature labor. Okay, and during deliveries, laborings, you will get neonatal malaria. You have a chance to get the malaria infection in the baby. Okay. Yeah, I think
Okay.
it's
Maybe it is
anything else that you
pretty
want to
clear.
ask me. Yeah.
Okay, maybe once more. Who wanna press the raise hand button?
Yes.
It is still a little minutes more.
Yes, please.
Please use your opportunity to actively participate and discussion here with the expert.
I think all of you have my email, right? Otherwise, you can ask Professor Kurnier. You can email me later if you would like.
Okay.
Yes. We know
Okay.
each other now. You keep contact. If I
Yes.
cannot
Of course,
remember you, I
Professor.
will ask you to be Tasri and Kurnier whether
Yes, of
this is
course.
our group or
I
not.
will email you.
Okay.
For further question.
Yeah.
Okay. So maybe I would like to express our gratitude for Professor Cassini's wonderful answer and sharing today. Big appreciation too for Mbak Anggi, and then who else? Andriani, and then Miss Nia, and then Miss Hannah, and then the last two, Karin Sinakari Winrod, to join this interactive discussion session. And then before we close this second session, it will be a certificate for Professor Cassini for the lecture this morning. Thank you for your great topic today. Congratulations, Professor.
Thank you very much. Nice to see you all. Have a very good New Year's. And hope to see you.
Very
in
nice to
person.
meet you.
Yeah, nice to
Okay.
meet you too. Thank
Okay.
you. Sawadee
You're welcome.
ka.
Sawadika.
Bye.
Okay. So this is the end of the session, and I will return the time and screen to Miss Olivia. Miss Olivia, time is yours.
Okay, thank you very much, Mrs. Chuitasari and Professor Cassini Kotifanik for giving us such informative and wonderful presentation. And finally, we came to the last session in the short course today, that is closing. As the master of ceremony, once again, thanks to Dr. Heni Trirahayu, PhD, and Professor Cassini Kotifanik as the speakers, the lecturers, the committee, and the audience entirely from Indonesia, Malaysia, Thailand, and Philippines. May what we had conducted today will be useful for us. So, ladies and gentlemen, if in guiding this event I made mistakes or offend someone here, please forgive me. So, well, ladies and gentlemen, thank you very much for your coming and your nice attention. See you tomorrow in the next lecture at the morning. Have a nice day and good morning, everyone. Thank you, Professor Cassini. Thank you, Dr. Heni. Bye-bye.